So Nigel, would you mind reintroducing yourself to the audience and telling us a little bit more about yourself?
Nigel Hocking, as Mick said, I'm from Director of Paediatrics at Melton Health, which is part of Djerriwarrh Health Services. Melton Health is a fairly new facility that was established about 8 years ago, and it's a community paediatric service. And we operate on a multidisciplinary model, so we have paediatricians, an allied health team with developmental psychology, speech pathology, occupational therapy, audiology, social work, and a whole range of people. And we concentrate on seeing children who have complex developmental and behavioural needs, in performing an assessment of those children as a baseline, but also in terms of short-term intervention for those children with significant delays and long-term paediatric intervention. And a short-term intervention is provided before early intervention services take up the children. We have a community health component too, which is for children who have more straightforward needs in one domain. And we run a number of multidisciplinary clinics, including an autism assessment clinic, a developmental assessment clinic, behavioural assessment clinic. We have a weight management clinic, and a number of group programs are run by the allied health team. So we do a secret agent society social skills program and a number of other programs which are run through the organisation.
Actually, good to hear other folks organise their services. Thank you for that. Now, back to the topic. Now, what EPAs did you and your trainee choose, and why?
Well, basically it came from what we can give them from our service, and so the goals were discussed between the trainee and myself, and it reflected the sort of things that we do. So the assessment, management and treatment of children with ADHD, the assessment and management of children with autistic spectrum disorders, working as part of a multidisciplinary team, and how you put that all together and put a plan and long-term care plan in place. And so they were the sort of the broad things that we look at, and we wanted to see if they could have competence at the end of their period that would allow them to do these things independently and competently.
Mm-hmm. And what were your initial expectations of the pilot, and were these met?
Yes, in short, it was the way that we'd done things, so that we've been running for about 8 years, and we'd started off having a paediatric fellow with us for a day and a half, and they were quite senior. Most of those are sort of in their last year of training, so they're very skilled, and it was very easy to establish a set of goals, and that's the way we think and that's the way we do it. So we'd been kind of doing it this way anyway. So it came naturally for us to do it, but certainly the trainee with whom I did this had also come to me and said, look, I really want to do it, and I want to set these goals. And so we talked about them, and we established them in that sense. So it was not unfamiliar to us as a model, but we've only had a full-time registrar with us for the last 2 years, so it's a relatively new situation in that context, where they're there all the time.
So they had some face validity. They actually represented what you're actually doing.
Yes, absolutely.
Yeah.
And as I said earlier, it was also based around my experience as being in a much more general hospital, with general paediatric trainees, about whose skill level I had concerns in terms of training.
Okay, so you've brought in that extra level of experience. How has the EPA pilot impacted upon your performance as a supervisor?
Oh, it's quite a lot. I mean, it's much more intensive. We do a lot of one-to-one. Certainly in our autism assessments, what we do is have the candidates actually sit in and watch us doing it, and when they feel comfortable, then we sit in and watch them. And in terms of what sort of skill level, will they do the interview? When they feel comfortable, they can also do the feedback and the plan to the parents, but they're usually at different stages over the time. And so, but it means a lot more time in discussing patients, discussing patients after they've seen them, in sitting in and observing what they do. So when we started with the full-time registrar, I actually had to cut my clinical load down by 50% to actually be able to accommodate it.